With regard to early stage breast cancer, we think about it within each of the subgroups. So the HR positive, HER2 negative, which is about 60%, the HER2 positive, which is about 20%, and the triple negative, which is about 15%. The greatest advances have been in the HER2 positive breast cancer, early stage cancer, which used to have the worst prognosis in the era before HER2 targeted therapies. Now we have multiple HER2 targeted therapies that we use. We've moved to neoadjuvant therapy for most patients with HER2 positive breast cancer if they're stage 2 or greater, 2A or greater, and they're still operable. The reason is that we're looking for a pathologic complete response, and we can adapt therapy if they get it or if they don't. They do receive a year of adjuvant anti-HER2 therapy with trastuzumab, with or without pertuzumab if they're node positive in the adjuvant setting. If they get neoadjuvant therapy and they still have residual disease, in other words, they don't have a PCR, they now get TDM1 as the standard of care, and that has elevated the response rate. And the focus now in HER2 positive cancer in the early stage is to optimize therapy, to de-escalate therapy when the risk is lower because the drugs are so effective. And we can do that in stage 1 cancers. And to escalate therapy when they're still at high risk of relapsing. So I think we're honing in HER2 positive cancer on the best way to treat almost every patient and to reduce toxicity but preserve that meaningful relapse-free survival.
So yeah, key takeaway is that metastatic breast cancer and the treatment profile is rapidly changing. It's becoming a little bit more complicated, but I do think genomic profiling is becoming more and more important in treatment selection and clinical improvement.
Probably a few main things. One is that in high-risk resected kidney cancer, adjuvant pembrolizumab for years is standard of care. I talked a little bit about the nuances of applying it to higher risk patients and some of the pending data regarding survival, but that is the new standard of care, and there are many other trials that will be coming afterward to refine that. In the metastatic setting, anti-PD-1 based doublets are the standard of care. So there's 4 that have extended survival. 3 of them add in a TKI partner, a VEGF TKI, and 1 adds in ipilimumab, a CTLA-4 inhibiting agent. They're all standard of care. There's pluses and minuses and nuances about giving them, but that the era of kidney cancer we're in is very much the IO doublet care, and we're heading towards 3 drug regimens.
The main takeaways, so I talked about both metastatic castrate-sensitive prostate cancer and metastatic castrate-resistant prostate cancer. So those are 2 different therapeutic spaces in prostate cancer. The main message by far, we have a lot of treatments available for prostate cancer today. So over the last several years, lots and lots of treatments that have prolonged people's lives, made people live better, and really great advances over time. And the tendency now, and the trials are showing us that combinations, intensification in the upfront setting, and possibly combinations in the metastatic castrate-resistant setting will also end up being beneficial down the road. So for castrate-sensitive disease, the main takeaway should be that patients with metastatic prostate cancer upfront, castrate-sensitive space, benefit from intensification. It's unclear right now if that's going to be a doublet with chemotherapy plus ADT or with oral hormonal agents plus ADT, or if it's going to be a triplet with chemotherapy plus oral agents plus ADT. That's still 2 positive trials right now suggesting that triplet intensification could be beneficial, but we still have a lot to learn about burden of disease and exactly which patients are actually going to benefit from triplets. But very clear that intensification with doublets as a standard of care right now is the way to go for castrate-sensitive disease. In the castrate-resistant setting, the key takeaway is to do more and more to keep in mind to offer patients a molecular profiling, both to catch for somatic abnormalities as well as to catch for germline abnormalities. And that in their lifetimes, in the patient's natural history, there's more and more opportunities to, for instance, use PARP inhibition to address patients with homologous recombination. The question that is now being posed is there going to be a role for bringing those PARP inhibitors earlier into the disease process or to do them sequentially? We don't know the answers to those questions so far. Emerging trials, early data, still I would not do combinations, but that's evolving. But definitely the key takeaway is the importance of doing molecular profiling and germline profiling on those patients to make sure you're not missing a homologous recombination abnormality.
Yeah, so I think the key takeaways kind of go into three different categories. So the first is on immunotherapy. And so immunotherapy has transformed the landscape for upper GI cancer, so gastric, gastroesophageal, and GE junction tumors. So the two kind of highlights were the updated data from that Checkmate 649 trial, which established the benefit of nivolumab plus FOLFOX or CAPOX in adenocarcinoma histologies. The other big takeaway is that what degree of PD-L1 expression is enough. So we know that in that trial, all patients got benefit, but it really seems that it's being driven by higher CPS scores. So it's still a big debate in the field as to, even though all patients can get immunotherapy in this space, should they? The second big trial was that Keynote 590 study. So that was in largely esophageal tumors, and that included squamous cell carcinoma patients as well. And so this study, the long-term follow-up also established the benefit of adding pembrolizumab to cisplatin and 5-FU. So really kind of interesting because we have these two overlapping approvals. So basically in gastric and GEJ adenocarcinoma, either pembro or nivo work, but in esophageal, in squamous, we only think about pembrolizumab. The other big takeaway was in neuroendocrine tumors. So the importance of separating neuroendocrine tumors, which are well differentiated, tend to be more slow-growing processes versus neuroendocrine carcinomas, which are highly aggressive tumors, and some of the drug development efforts that have gone into each. So for neuroendocrine tumors, some of the most promising agents that are being tested are these anti-blood vessel drugs, anti-VEGF TKIs. Two that are super exciting are surfatinib and cabozantinib. Hopefully the former will get approval quite soon. And the other approach is building on the activity of peptide receptor radionuclide therapy. So there are a lot of novel approaches adding DNA-damaging agents to that. In neuroendocrine carcinoma, we're looking at the addition of chemotherapy to immune therapy, kind of like small cell lung cancer, and also novel agents in the later line setting, things that damage DNA in addition to established chemotherapy regimens.
And a lot of what we talked about was the use of immunotherapy and how can we to treat our patients, with these immune-based therapies potentially with the goal of improving, outcomes in more patients. We talked about for patients who have localized colon and rectal cancers that it is also characterized by an MSI high status. That early data thus far suggests that the use of immunotherapy, anti-PD-1 therapies, is associated with very, very good treatment outcomes. And we're seeing in multiple series, patients who are able to potentially forego conventional therapies and the toxicities associated with them by use of these immunotherapies. In that context. We also talked a little bit about the role of immunotherapy in patients with BRAF mutations. This is a population of patients with colorectal cancer who traditionally don't respond as well to standard chemotherapy as patients who don't have BRAF mutations. And while there are recent FDA approvals with targeted therapies in this context, there's reason to think that BRAF mutated microsatellite stable colorectal cancer is associated with perhaps higher baseline immune activation and may favorably benefit from combination approaches which utilize MAP kinase directed therapies in combination with immunotherapy. In the specific example today at the Total Health Conference, we presented results from two trials focusing on one that looked at a BRAF EGFR combination with immunotherapy, encorafenib, cetuximab, and nivolumab in this context. We looked at data from a single institution study at MD Anderson, but the results are very promising in the initial cohort of patients who were treated with this combination. Overall safe and well tolerated, promising clinical results. But again, as in the case with the use of immunotherapy and MSI high local regional therapies, we really aren't going to understand for sure what's the role and benefit of adding immunotherapy in these particular contexts until formal dedicated clinical trials have been completed. And so we also talked about those and wanted just to make sure that providers are aware of various trials out there which are able to provide the much needed evidence for benefit potentially in these particular contexts.
Key takeaways from the discussion were the way that we manage non-small cell lung cancer pretty much in the metastatic setting. And the goal initially of the talk was to convey the importance of screening. So we really don't want to be treating metastatic lung cancer because we know once we're there, it's pretty much too late. So the goal initially was to talk about screening. Then we talked about immune checkpoint inhibitors as monotherapies for non-small cell lung cancer, and then combination immune checkpoint inhibitor therapy, and then we discussed the chemotherapy with immune checkpoint inhibitor combinations that are currently used in stage 4 disease.
So I tried to give an update on COVID and cancer and where we've been and what our patients have struggled with for these past couple of years. And in the end, the bottom line is that cancer can't wait. Patients really need to proceed on with their screening, with their treatment, and there just don't need to be delays because ultimately it's going to wind up for a higher mortality for them. In addition, if they were to contract COVID, they have a higher risk of death from the disease. And if you add any other comorbidities on top of that, then the outcome can definitely be worse.